Hello, my name is Anthony Effinger. I'm the host of the Think Neuro podcast, and I'm here today with Dr. Chester Griffiths. He's one of the 4 founders at Pacific Neuroscience Institute, and he's the director for the Center for Eye, Ear, and Skull Base Surgery. Thanks for joining me.
Thank you for having me. Very excited.
Yeah, when people think about Pacific Neuroscience Institute, they think about minimally invasive surgery on the brain. And I've heard some pretty astounding things about people being in and out of brain surgery in 2 days. Is that correct?
Yes.
And how are you able to do that?
Well, we're able to, so to speak, sneak in and sneak out using normal anatomic corridors that are normally filled with air to go into different areas of the brain, the base of the brain, and remove tumors, growths, infections that originate at the base of the brain, where before they would either have to come through the side of the skull or the top of the skull. And when doing that, you would disrupt some of the brain and you would handle some of the brain. We're coming from below that. So many times we don't even touch the brain, but we see it. And in that, it's a much better approach for preservation of function.
You never probably want to handle the brain. Is that right?
Well,
Or minimally?
Minimally. I mean, neurosurgeons do it every day.
They do.
But a no-touch philosophy is a much better one. Touching the pathology, removing the pathology, and not disrupting any of the normal tissue.
So you're an otorhinolaryngologist. Did I get that right?
You did. That's a great job the first time.
Tell me what that is.
Many people can't say that. It's a tongue twister. Of course, it's Latin. Oto meaning the ear, rhino meaning the nose, and laryngology meaning study of the diseases of the voice box, the larynx. Basically, it's everything above the clavicles without including the eye or the brain. So clavicle to follicle, no brain, no eyes, but here at Pacific Neuroscience Institute, we've instituted all of those disciplines and specialties together.
Okay, so you're the everything up in here beside the brain and the eyes.
That's correct. And the head and neck.
The head and neck. So tell me, what are the sort of procedures you're doing every day you're in the OR?
So it can range from taking tonsils and adenoids out in children to sinus surgery for sinus infections, reconstructing the nose to improve breathing that may cause sleep apnea, issues related to cancer in the area. Interestingly enough, human papillomavirus has come to be a very common cause of cancer in the ear, nose, and throat area. So we're seeing an uptick of that now that people aren't smoking as much, which was historically a very common cause of throat cancer, voice box cancer, tongue cancer. So treating those cancers in the area, and of course, performing minimally invasive endoscopic skull-based surgery, which is using the corridors of the nose and the sinuses to go to the base of the brain so that we can remove pathologies and diseases without touching the brain.
Now, that's what your role is here at Pacific Neuroscience Institute? That's where you become working very closely with neuroscientists.
That's correct. With neurosurgeons, neuro-ophthalmologists, orbital surgeons, and reconstructive surgeons. When we do big procedures, we have to obviously put the patient back together. But it's all done very minimally invasively, almost like a no-touch philosophy, only touching the pathology, the tumors, and trying to preserve the normal function of the brain, the eye, and the spinal cord.
So tell me how this works. You go in through the nose, is that right?
Yes, that's correct.
So take me through one of these procedures.
So my role with Dr. Kelly, and we've now been working together in this endeavor, which has really been a journey, being some of the first practitioners and surgeons involved in pushing the envelope since 2001. I create the corridor, so to speak, to be able to get 4 hands and 2 nostrils.
Wow.
And the instrumentation to give us the ability to do these procedures. And some people have asked me, it's kind of like building a ship in a bottle, and in a sense it is. The technology has allowed us to push the envelope with digitization, digital media, pixelization with really fine tuning and colors and definition of the anatomic structures, and the instrumentations that have been developed specifically for these procedures, along with neuronavigation, which is having an MRI or a CAT scan in a GPS manner. We're able to see within a millimeter and sometimes spot on exactly where we are in a 3-dimensional plane. And that allows us to have accuracy, allows us to have safety, and allows us to preserve tissues that normally we may not have in the past when we didn't have that 3-dimensional image guidance, or so to speak, GPS.
Is this a real-time MRI that's happening? Or
It is not real time in the sense that it's updating. So there is a static image. But when we're removing a tumor, we know that when we have our instruments in that space, we don't need it to be updated because we know that that's gone.
You have the map, sort of.
We have the map, that's correct.
Okay.
We do use some real-time guidance with ultrasound, and especially Doppler ultrasound, where we can actually hear the arteries of the brain, the carotid arteries, the cerebral arteries, and it really helps us stay safe, because just 1 millimeter away, we may be right on the carotid artery and we can hear it, and we know that it's right behind that tissue. And with disease, the tissue's not normal. It's very simple to do it in a normal anatomic specimen, but the playing field has been altered by the pathologic process. So we use all of these tools to help and guide us, but truly it's the judgment and experience that really has made us better and better over the years. There's no question that the more you do something, the better off you get. Experience breeds that bravado, but we also are very humble. We always, we don't put the patients at risk. We could always come back another day. Safety first.
Sure. What are the geometries we're talking about here? You're talking about you're in some very small spaces. Is that right? So you're going in here. Tell me about the size of the access point that's through the nose to the base of the brain. I mean,
so interestingly, it's almost like a triangle. It's wider in the front, narrower in the back as it kind of comes down. So the sphenoid sinus, which is a sinus right in which is an air-filled cavity. Our head is filled with these cavities of air, and this one cavity is right in the center of the skull and right in the center of the brain. The front of that is about, it could range from anywhere from 4 to 6 centimeters in width, and 4 to 5 centimeters in height. Some are smaller, some are larger, depending on the age of the patient, because the sinuses, very interestingly, they bud and they almost flower into the skull, almost like a rose petal flowering out, and you have these cavities that are filled with air, and they're very haphazard in size, just like a rose petal. It's no rose petals the same
Yeah.
size, and there's no sinus that's exactly the same size. They're all different.
Why do we have sinuses?
Well, that's a great question. There's a lot of theories about them. I think one theory is that it takes away the weight of the head, so
Okay.
we can actually stand up. I don't really believe that. I think it's related truly to have a mucus lining tissue surface area, because the lining of the sinuses produces the mucus that holds immunoglobulins, enzymes, other proteins that help maintain a clean environment in our nose and our throat.
Interesting. Okay.
And it lubricates our nose and our throat. So everyone feels that it's our saliva that lubricates our throat. No, our saliva is for digestion. Actually, the mucus that comes out of your nose lines your entire back of your nose, your throat, and your lower throat. So then when you breathe, swallow, or speak, it's not dry. There's a thin layer of this mucus blanket. And that mucus blanket has protective immunoglobulins in it, protective enzymes, protective substances, so that you don't have an overgrowth of bacteria
Okay.
or other things. So
So for you, it happens to be this fantastic
lining-
highway into the brain.
Yeah, that's correct.
Okay.
So we take advantage of that.
Yeah.
Because it's an open airspace. And we don't have to really, our philosophy is preservation of the physiology and the function of the nose and the sinuses in our approach. We try not to remove any tissue if we can. It's more of an incisional, a cutting technique, not an excisional removal technique. And we've kind of come to the how we explain to patients is I come in and I open the draperies of the stage for the main event, and then Dr. Kelly and I participate in the main event together, and then at the end we close the draperies back and then we go home. And so it's like the curtains of a really spectacular performance. And in that, we preserve the sense of smell, which historically was a pitfall of this surgery because in the early days, surgeons would remove all that tissue.
To do this.
And granted, the feeling was, well, we're dealing with a much more complex, problematic problem than in the brain. Well, if they have a smell problem, that's lower on the hierarchy scale of problems.
Sure.
But if you can preserve all those functions, especially smell, patients are much happier.
I'm sure they're much happier. Yeah. So what are you going after? What can you reach from this route?
So basically, it is a very simple way to look at it is we have the goalposts, and those are the carotid arteries. So the carotid arteries come up through your neck, and they go and they feed the main arterial supply of your brain. And in the center portion of the nose, on the outside are the carotid arteries. Going beyond them, we can get into trouble with the cranial nerves, the nerves that move your eye, that give you vision, that move your face, and help you swallow, help you move your tongue. So the carotid arteries, those cranial nerves, come on the outside of that arterial structure. So we stay inside of that. So anywhere from the top of your eyes, in between your eyes, all the way back to the top of your palate, that whole arching area is the zone where we can work safely.
Okay.
There are some approaches where we go lateral, but we go down low underneath the cranial nerves so we don't hurt them. Through the cheek sinuses, because the cheek sinuses, of course, are right under your eyes, full of air, and you can go through the back wall of those sinuses and approach different disease processes. So it's very intricate and exciting in the sense that we are using these developmental peculiarities to our advantage.
Well, is this why it's so suited to pituitary surgery? Because the pituitary is right there?
Right in the center, yes.
And you can get to that.
Yes. But we can get to other benign growths. For example, the meningiomas are, the brain sits in a baggie, so to speak, an envelope, and the brain sits in its brain fluid. That envelope or baggie is the meninges. And you can develop benign tumors anywhere, benign growths, and one of them is meningiomas. So anywhere where that, there's the lining or the baggie of the brain, you can develop a benign tumor, and that can happen from the front all the way back to the back.
So you can get at some of those by doing this.
The ones that are in in between those goalposts.
When you say, is it really like a baggie?
It's a little bit tougher than that, but it's I mean, you cut it and then the brain fluid comes out.
It's tougher than a baggie.
It's tougher than a baggie, yeah, because it's got various layers into it.
So if you take a tumor off of that, do you violate that?
That's correct. And that's a great question, because one of the most important aspects, aside from the technologic advances, and I call it the Apple phenomenon, because, technology is, since the iPhone, since the smartphone, not Android people, I'm not trying to. No, we'll just say the smartphone.
Sure, fine.
Since the development of the smartphone technologies have just exponentially exploded. The last 10 years, 12 years have been unbelievable. But getting back to basics, when you open up the base of the brain, you have to close it. And you're opening it up to an area where bacteria live, and an area where there's a airspace. And one of the discoveries was we can take the lining of the septum, which is the divider of the nose. It divides it into two cavities, the right and left nostril. And we could take that mucus lining tissue connected to an artery. So it's a vascularized flap. And we take that and we then reline the entire base of the brain. So we close the hole with live vascularized tissue. So we're closing that opening where the brain fluid would come out with that tissue from the nose.
That you take from the nose in this same procedure?
Yes.
So you're on the way in or something, or?
So we have developed a special technique called rescue flaps. This may get a little bit too technical, but instead of removing the tissue, we push everything out of the way, preserving the arteries that are feeding that tissue so we don't burn any bridges. More importantly, we're not cutting the artery, so a bad nosebleed is less likely to occur.
Sure.
And believe me,
that happens.
That has happened, not in our experience now, because of this technique that we use, because we're not cutting the artery. In the days prior, they didn't realize just because of the evolution of the discipline, they didn't think it was important to save that artery. So going in, they would cut it, and of course, sometimes that would bleed. But the main issue is that they were cutting off that supply to the mucus lining tissue of the septum, which you then could not use to reline the brain. But so coming in, we prepare for that, and then we look, and then we decide if we need that, and then we just raise that flap of tissue. We measure the size, so we only take what we need, and then we rotate it up and close the hole. And that is one of the major developments, because the biggest problem with doing it through the nose was a brain fluid leak and then meningitis. And this ability to close the hole reliably has really changed the face of this procedure.
When did that start? When were you able to do that?
About 10 years ago.
And what happened? How did that evolve?
It was, it came from, one of the four corners of the world. It came from two ear, nose, and throat doctors in Argentina.
Really?
And they came to the University of Pittsburgh and presented this technique, and we haven't looked back since.
So technology has made your job a lot easier, it sounds like, especially in the last 10 years.
Yes.
So what happened in 2001? Did you say that was when you did the first?
Yeah, so Dr. Kelly and I, we did a lateral skull-based procedure through the nose.
What does that mean?
So in other words, we came through the nose and didn't go straight ahead to the pituitary, but onto the side through that maxillary sinus. We both pushed to do it together. He was my backup in case we got into the brain. I was his backup in the nose. And so we both were supporting each other. And when we did the procedure, it went so flawlessly that we said, okay, that we gotta put some time and effort into this.
And what were you after in this procedure? What were you going for?
This was actually a schwannoma. It was a benign tumor of the sheath of a nerve. So, like, if you've ever seen a ganglion, that people have, that's a benign tumor of a nerve sheath. And this schwannoma was in the back of the maxillary sinus under the eye and pushing up into the brain. And it was just a benign growth growing. And we removed that schwannoma through the nose.
And was that, what was that considered sort of radical to do this at
very
that time?
Novel, very novel. Because the technology, the cameras weren't, the video cameras weren't high def. Not even close. The endoscopes were very good, but the monitors weren't high def. The instrumentation wasn't long enough, so we had to think quick on our feet and borrow instruments from others like orthopedics and other endoscopic specialties. That was a kind of a watershed moment for both of us.
So what was the alternative? I mean, how would you have gotten in there if you wouldn't have?
They would have come on the side of the head.
And that would have been
the craniotomy. Yeah.
And craniotomy, that means taking a piece out of your head, out of your skull.
Yeah, that's making an incision on the side and then removing the bone on the from the cranium and then going in that way. And then at the end, you put the piece of bone back. And
much more invasive, much more,
Yeah, it's still done very commonly today. There's certain tumors that you can't do endoscopically. You just, the pathology dictates your approach in relation to preserving the normal functional structures. So, very honestly, keyhole surgery, though, is evolving. The keyhole surgery meaning minimally invasive surgery.
That's what we're talking about here.
Yeah.
Okay.
So we term it minimally invasive maximal surgery. So in the sense that if you did it open or through a craniotomy, you're still doing the same procedure with the same outcome, but you're not doing the big approach. You're not doing the big incisions. You're not, removing that piece of bone from the skull. But it's still the same maximal surgery, but it's just minimally invasive, and so patients recover much quicker.
Sure.
They go home, 2 to 3 days after surgery. They're up and around very quickly, and even their friends can't believe that they've had brain surgery. Yeah. And I call it almost a big fake out, because after 3 weeks, they want to get right back into their normal routines of going to the gym or, going to amusement park or.
And is that off limits?
For the first month to 6 weeks. Okay. You still have the healing period of the maximal surgery.
The surgery that you didn't see. You can't. There's no evidence of here, but it's back there.
It is there. Yeah. We removed the same size tumor, but of course in a minimally invasive way, and so patients feel, hey, I'm ready to get back into the game. And we have to remind them, no.
You had brain surgery.
Yeah, you had brain surgery. You have to heal.
Yeah. I want to come back just to this first surgery.
Yeah.
How did you figure this out? How did you know this one, you could attack this one this way?
Our other colleague, Dr. Howard Krause, and I, at the same time, removed a orbital tumor that was causing blindness in a gentleman, and the neurosurgeon and the neuro-ophthalmologist had recommended that the patient just go blind, and then they would remove the tumor because they felt they would blind the patient removing it. And so we went through the nose, so we didn't have to come from the outside in through the optic nerve. We came on the side of the tumor and we pulled it out through the nose. And it was a procedure that went flawlessly, but in a sense, the burden of the risk was taken off of us because the patient kind of resigned himself that he was going to go blind by this tumor, and any chance of not doing that or having that as a sequelae, he was willing to take, and it gave us the opportunity to push the boundaries on minimally invasive transnasal endoscopic surgery. So it's through the nose with the endoscope. And once you get your feet wet and see that it's possible, then you start to push the boundaries and you start to say, well, and this particular procedure, Dr. Kelly asked my opinion if we, what approach would I use? And after meeting the patient and then studying the case, I called them back and I said, we can try to get this out through the nose. If we can't, then we always have what's called a lateral terraronal approach. We can do that. But obviously we didn't have to do that.
And so in the first case, did the gentleman did the lady preserve her sight?
Everything. Yeah. Oh yeah. The first, he actually sight completely returned.
So what kind of tumors can you remove through the nasal cavity?
So mainly the ones that are between the carotid arteries, and that the most common is a pituitary tumor, an adenoma, and there's some pituitary tumors that secrete a hormone, and some that are just growths that are not hormone secreting. Common one is called Cushing's disease, which secretes cortisone. Another one is a growth hormone secreting tumor, which causes gigantism. But the majority really are ones that don't secrete a hormone, and they present sometimes with a severe headache or with the loss of vision because they grow and they push on the optic nerve. And then kind of the blinders come from the sides in. And people start to lose their peripheral vision. Patients do. So then the most common is a pituitary adenoma. Then there's meningiomas, which are the benign tumors of the covering of the brain. There are congenital tumors from birth, one called the craniopharyngioma, a Rathke's cleft cyst. Sometimes in the development in the embryo, one cell will get trapped in the brain by accident. And then that cell is not supposed to be in the brain space, but it continues to grow. And so they grow into cysts, benign cysts.
And you can get those.
And then
what size are we talking about with all of these?
So, a adenoma can be as small, a microadenoma can be as small as 2 to 4 millimeters. A macroadenoma could be the size of 5 to 6 centimeters.
Or around the pituitary?
Yeah, or growing out of the pituitary, yes.
Really?
The majority usually are about 2 centimeters, 1.5 to 2 centimeters in size. The macroadenomas, the ones that grow outside of the sella. The sella is the home of the pituitary gland, and the pituitary gland has been called the master gland.
Yeah.
Because it's, secreting all these very vital regulating hormones that regulate a lot of the body functions.
It's some pretty precious real estate.
No question. Very, very, very important.
But the pituitary lives in there?
Yeah, right in the center, right between the carotid arteries.
And how small a space are you working in?
So anywhere from a centimeter in width to a centimeter in height.
Okay.
To 2 centimeters in width and 2 centimeters
depending
in height.
on the person.
depending on the person.
And then how do you get a tumor out of there?
So there's basically, to make it simple, two types. Ones that are cottage cheese consistency, and those you can dissect off the normal structures and then slowly kind of remove them with instruments, almost like scooping out ice cream, if you will.
It's not a vacuum situation?
Well, we use suction and dissection and suction. And then there's the rubbery ones, the ones that are firmer, that are a little bit more stuck. And those you actually have to cut and dissect and remove piecemeal. So you don't remove it in block. You cut pieces out because that allows you to get around and preserve the normal tissues. So you're almost like, if you will, slicing, a salami. You're taking slices out so you can get further back and closer and cutting the
all the while avoiding the pituitary.
Avoiding and protecting the normal pituitary gland that's many times been pancaked. It's been crushed by the tumor. And, of course, avoiding the carotid arteries and the cranial nerves.
Okay, so what is in your hands when you're doing... What do you... I imagine like I don't know.
So there's basically four hands. One is driving, in my hand I'm driving the endoscope and the camera. And in a real sense, I'm the cinematographer of this performance. And in that, I'm actually doing the surgery by showing the different areas of the procedure. Going in and out gives the eye a three-dimensional view of depth, because when you come closer and farther, you're getting a depth perception. So when you're putting your instruments in, you know exactly how far and how close to come. It's truly creating a three-dimensional image in your mind by going forward and backward with the camera and the scope.
And the scope, but what is it? You have the ends of this thing. You have the controls.
Yeah, so I'm holding it, but the scope is a very narrow tube.
Straight?
Straight. And they have, at the end, they have angle prisms. So we can look straight ahead. We could look 30 degrees, 45 degrees, 70 degrees. So we can look at a spectrum. And then by turning the scope, we can see 360 degrees by just rotating the scope. So we can almost see the whole kaleidoscope of the areas. And of course, that scope is the scope is designed to give you a real-time image at the tip of the scope, almost as if your eye was right at the tip of the scope. So we're able to see right inside of the sella, right inside the cavernous sinus, as if our eye was right there.
That's amazing.
Yeah, the technology has allowed us better precision, and actually, we believe we do a better job removing most of these tumors because we can see 360 degrees. In the traditional approaches with the microscope, you are limited because you're looking down a barrel. With the scope, you get that added advantage of seeing onto the side, seeing up and seeing down.
So you have pretty steady hands?
So far. Hopefully you don't know something I don't know.
So how did you get into this? This is tough stuff, right? I mean, you're in there in some of the most important structures in the human body, right? That's a big job.
When you're doing this, you don't think about that. You're just kind of evolving and trying to figure out a better way for your patients. And yes, there's risks, but with a team and a conglomerate of great minds and passions, you can do anything. And I think that's the secret sauce here at our institute. It's grassroots, homegrown. We've brought this up from the basement, and we're all like-minded, really different. We're all different personalities, but we all have the same mission in mind. And with that, sure, we've had times when things haven't gone well, but the majority of the time things go great. So I don't think it doesn't come a time where you think, oh my God, what am I doing? You're mainly thinking, okay, how can I help this person? What is the best way? I call it the most competitive contact sport you'll ever play because surgery is physical. We are on our feet for hours, holding instruments very steady. We're on a clock.
Yeah.
We want to score the touchdown. We're never allowed to lose. Patients don't come and say, okay, doctor, you can give me 60% today.
No.
And so we are always trying to score that touchdown for every patient. And in that, there's a lot of preparation and insight, and of course humility. When we can't do something, we're very frank and honest and say, this is not appropriate, or we'll come back another day, or there's another avenue. It's very very selfless in a sense. All the colleagues here really have no egos, which is great. They're being in a group of brilliant minds and passionate people just brings you to another level as an individual.
Yeah, it's got to help that it's two of you, especially you and Dr. Kelly on these pituitary surgeries. I mean, that's what a benefit for the patient to have, two surgeons who are.
There's no question, because you have four eyes looking.
Yeah.
And just as someone will look at a Mona Lisa and have their impression of what they see, and the person next to them has a completely different impression, it's the same picture. You're seeing different things. And in that, it adds a level of safety, because he's seeing or focusing on one thing, and I may be focusing on something peripheral.
Sure.
And I may see something happening that he's focusing on another area, and we'll be able to guide each other through that this kind of process together. So you're absolutely right. Having two surgeons with experience, albeit different, is exponentially better.
Oh, sure.
There's been many times where Dr. Kelly has seen things that I haven't seen, and he goes, "Hey, what's that?" And and there's conversely, I'll do the same thing. I go, "Dan, what about that?" Oh, and it's not that. It's just the way the mind works.
Sure.
Yeah,
well, the guy who did my meniscus surgery was alone, but that's a meniscus, and it's way down here in your knee, and that's probably fine.
Yes. But it's and in the same sense, we challenge each other. There's not a day that goes by that we don't joust and disagree.
Well, you're surgeons, right?
Yeah, exactly. But at the end, we agree to a game plan, and but the process is just as fun. It's I think our wives are very jealous
of your relationship.
Well, they always question if we're really doing surgery because of the hours that we spend together. But we tell them no, it's platonic.
We're not on the golf course.
We're not on the golf course.
This is what we're doing.
We're not down at the saloon.
Yeah.
We are actually doing that, and I have to find my friends on my phone, so my wife always knows I'm in the operating room. She checks on me.
So you've shortened the time to say for pituitary tumor, you shorten the hospital stay to 2 days?
Sometimes 2 days, normally 3 days.
Okay, good.
And so it all depends on the patient. Interestingly enough, it also depends on the time we do the surgery. If we have a morning start, we usually can do two surgeries a day, maybe 3. And if it's a morning, then that patient can probably go home on the afternoon of the second day.
Amazing.
If it's in the evening, then they may stay an extra. So it's basically.
Nonetheless, I mean, either of those is a short. I mean.
Oh yes.
I mean, that's nothing. I mean, what about in the old days when you had brain surgery? What were you looking at?
Well, pituitary surgery was done microscopically, so the times in the hospital, were still 3 to 4 days. But the other pathologies, you're looking at 7 days, 5 to 7 days when you're actually doing a craniotomy and opening the skull.
So what's the future hold? What developments are you excited about right now?
Well, nanobiology is the forefront, and just learning more and more about the genomic nature of disease. This next 10 years is going to be incredible. It's biologic therapies, aside from technically, are really very exciting. And just understanding disease on a nanobiologic standpoint, really getting down to grinding it down to the genomic level is going to change disease and health.
What do you mean? Do you mean that understanding the genomics of tumors?
That's correct. And then finding, for example, we all know friends or family that had the same type of tumor. One survives and one dies. Is that really the same type of tumor? No.
It has the same name, but
it has the same name. It looks the same by the pathologist when they look at it as slide, but there's something different about that tumor that will result in someone passing away versus someone that survives. There's something different. Now, of course, the individual patient has their own constitution has a lot to do with it, but we're finding that there are genetic or genomic differences. And now with these biologic therapies that we have, the ones called checkpoint inhibitors, it allows the immune system to actually recognize it as a tumor. These tumors fool the immune system, and the immune system doesn't react to them. And now we found that key of how those tumors, not we, but the medical community and pharma, et cetera, great researchers have found that key. They block it, and then all of a sudden the tumor is now apparent to the immune system, and your own immune system then does the cancer therapy.
So you kind of take off the tumor's cloaking device.
That's correct.
And all of a sudden the body's like,
that's not supposed to be there.
On this.
yeah, that's correct. That's not supposed to be there. And in a very kind of holistic sense, our immune system is doing that every day. There's there's trillions of
right
cell
now
divisions.
It could be
our
killing.
Immune system is finding these bad cell divisions and cleaning it up. It's part of its job. How these tumors develop is still a mystery. Some are viral, induced, like human papillomavirus.
Yeah.
But anyhow, having said that, that's one of the most exciting things I think in my career. Also, technology with patient education and patient understanding, I think is exploding. Patients come so much better informed, so much better equipped with knowledge than they did before. In the early parts of my career, patients would tell me, "Okay, doctor, do what's best." And they trust, and they still trust us. but they've done their homework. The availability of information is changed the game.
Yeah.
And good and bad, because then, in the sense, not understanding the information leads to some anxiety. But, I think that whole understanding of patients with the process, their bodies, their health, all of that is only going to benefit all of us.
So we're getting smarter.
I don't know if we're getting smarter. We're having. I think we just have access
to more.
To more information that then allows patients to be better informed.
Yeah.
And the human condition continues. We're not going to change that in a decade. But there's no doubt that patients are much more savvy today, and I like it because. Yeah. I don't want that responsibility entirely on my shoulders. I want a mutual relationship where the patients understand the challenges we have, and I understand the challenges they have. It's not now, doctor, just take care of it.
Yeah.
It's a much better team.
It's a team, I was going to say.
A much better approach. And the patients do better at the end of the day. I think they're more at peace with what's going on.
Sure.
The fear of the unknown is the greatest fear we have, right? I mean, and now that the patients have the ability to have self-education, and then they come in and I anecdotally say 50% of my day is spent dispelling myths and supporting truths. There's so much mythology out there. Patients come in, my neighbor said this, or my sister said that. And I said, no, that's not how it works. Let's step back and start from scratch. What medical school did your neighbor go to? What did they actually graduate university? And they're giving you advice
on your
health,
your brain,
and your brain.
Yeah,
no. But having said that, Dr. Kelly and I, and all the faculty here, one of our missions, one of our core philosophies is that we're patient health educators first. We do this every day. They do it once in a lifetime. So we spend the time trying to explain to all of our patients exactly what they're going through. These podcasts are one of those endeavors. This is, communication and explaining things are so important to the overall outcome of patients.
Well, it's got a lot to do with expectation, I'm sure, right? It sets expectations.
Expectations, no doubt, but I think anxiety and fear control. I think, that I can't put a parameter on this, but patients that come in fearful, scared, anxious, they bleed more, they swell more, they take longer to heal. Patients that come in ready, comfortable, accepting what's going on, they just tend to do better.
God, that's amazing.
And it's
amazing you can see that physiologically.
There's no question in my mind. And their blood pressure is the same. Their pulse is the same. The standard measurements that we have, physiologic measurements. But there's no question in my mind after my 30 years in practice now, and if you include residency and medical school, it's 42 years.
You started when you were 12.
Close.
Yeah.
But there's no question, and that's part of trying to alleviate that anxiety and fear. You're always going to have a component of it. As a matter of fact, a patient that doesn't have some component of it, I'm worried about.
Sure.
I want everybody to be a little bit, not fearful, but a little bit understanding of the gravity of what we're doing. But in the old days, I think it was off the charts. And I believe that this is all good. That's, education, these podcasts, the internet is, at the end of the day, is therapeutic.
Oh, good. Because it's questionable about the internet. But, yeah.
Well, no, I mean, it's questionable. There's a lot of I hate to use this term fake news, but there's a lot of misinformation out there. But that's our role.
Yeah.
That's the professional's role to say, this is real, this is not. And then to support the reality with fact and experience. But anyhow, that we try to be patient health educators first, and then the technical aspect, and we have really gifted doctors here. It's really, I'm proud to be associated with them. They make me better.
Yeah.
The old saying is, you don't play tennis with someone that's worse to you to get better, right?
No, that's precisely right.
You want to play against someone better than
And
you.
I hear Dr. Keller's pretty good.
I don't know about tennis, but he's pretty good.
Yeah.
He's a savant. There's no doubt. He's
fantastic. Well, I hope this podcast helps in that effort.
Yeah, I think it's going to.
Dr. Griffiths, I really appreciate you coming. This has been a really delightful conversation.
Fantastic. We'll have to do it again.
Yeah, absolutely. Oh my God, yes.